Yeah. And the work is going to be facilitated by each of us. And at the end of the day, we will come out of this with two, I believe, one per group, project plan, the start of those projects. So you are all our project planners today, and I do appreciate your help in this regard, because I know you're all enthusiastic and interested in helping us solve this problem, opioids. Yeah.
We're hoping to come up with some projects that we can deploy in our community about prevention. And also, there is money available. There's $10,000 grants available. So if we needed some money for some of these projects, that might be a possibility also. All right.
Money's a good thing.
May I introduce the brain power behind this entire event,
Woo!
the person who's coordinated it all miraculously, Crystal Eshelman.
All right, good morning, everybody, and welcome to our first North Central Washington Opioid Response Conference. The theme of our conference is Pathways to Prevention, and I am Crystal Eshelman, as he said, and I am so thrilled with the North Central Accountable Community of Health, and we are so thrilled to be hosting this conference on such an important topic. And right now, this conference is being broadcast and hosted at 10 different sites throughout North Central Washington. We have sites in Wenatchee, Leavenworth, Bridgeport, Moses Lake, Cooley Dam, Nespelem, Oroville, Twisp, Omak, and Colville, which is super exciting to be able to bring this conference to 10 different places in our region. We also have over 380 participants registered to attend this in our region, which is just an enormous response to this conference, which just shows how much our communities are wanting to get involved and really see what they can do and how they can help prevent this opioid epidemic. I do want to thank a couple of people that helped to make this happen. We have a network of over 30 volunteers that are manning each of the sites. We have group facilitators and site managers at each of those sites, and I just want to take a moment to recognize the organizations that have contributed and to this. So we have Cascade School District, Columbia Valley Community Health, Oroville School District, Family Health Centers, North Central Educational Service District, Bridgeport School District, Met-Hell Valley School District, Grant Integrated Services, Grant County Health District, Okanagan Community Coalition, Omak School District, Grand Coulee Dam School District, the Colville Confederated Tribes of the Colville, or the Confederated Tribes of the Colville Reservation, Wazoo Extension, and Northeast Tri-County Health District. That's an enormous amount of volunteers and organizations that are helping to bring this conference to all these sites throughout the day, which is amazing. We are using this distributed conference model, which was developed at Wazoo Extension by Deborah Hansen and Monica Babine, and they've done this several times as a statewide model, and this is the first time that we are using it outside of Wazoo Extension and trying to do it at a regional level, and so we're really excited to be able to bring this to our community. And lastly, I wanted to give a little shout out and thank you to our planning committee, Dr. Malcolm Butler, who is here in Wenatchee, Sonia McKee, who is at Moses Lake site, and the conference co-chair with myself, Chrissy O'Neill, who is at our Nespelem site today. And our executive director for the North Central Accountable Community of Health has a few words to say.
Thank you very much, and good morning. And what is so exciting for me is there's so many people in this room I've never met before. So that is exciting. So I'm Linda Evans-Parlett, and I am the executive director of the North Central Accountable Communities of Health. And why are we here today? We are here today because we have learned that at least 3 people in Washington State die every single day from a drug overdose. Addiction is an issue not only in our counties, our state, but across the country. And so we are here to see if there's anything we can do to work together to stop some of these things that go on and focus on prevention. We have to recognize that a lot of work was being done in Chelan, Douglas, Grant, and Okanagan counties already. And we didn't want to duplicate that. We wanted to work together and build upon it. And that's why we started sort of these rapid cycle grants where people can apply and receive up to $10,000 to do their own projects. And we're going to talk about that later. So I want to thank you very much for being here. It's exciting that we can have all these sites. We have our staff located all across north central Washington, participating just like we are doing here in Wenatchee. So Crystal, thank you for your great idea.
All right, so we'll start the conference off with two keynote presentations that will be delivered via webinar. Then we'll have a facilitated discussion and action planning activity at each location. And the purpose of this is to develop some community action plans or projects that can be implemented within the community. Following the conference, we will be offering a free Narcan training at each of the sites. And thanks to our conference sponsors, AmeriGroup, Coordinated Care, Molina, and Beacon Health Options, we're able to offer a limited number of free Narcan kits to those who stay and participate in the training. So that is a wonderful opportunity after the conference. For our first keynote presentation, I'd like to welcome Dr. Fatinas. Dr. Fatinas is the Deputy Chief Medical Officer of Washington State's Healthcare Authority. In her position, she provides support to both the Healthcare Authority and the Department of Social and Health Services in support of the Apple Health or Medicaid group. She is actively involved in behavioral health integration efforts with a particular focus on improving the access to and care of persons with substance use and mental health disorders. She is a co-sponsor of the Washington State Opioid Response Plan as well. Prior to her current position, Dr. Fatinas was the Chief Medical Officer for Public Health Seattle-King County. Dr. Fatinas is board certified in family and addiction medicine. Before joining Seattle-King County, she was a physician faculty member at the Providence Family Medicine Residency in Seattle. She holds a Master of Science degree in evidence-based healthcare from Oxford University Kellogg College in England, and is a clinical associate professor at the University of Washington in the Department of Family Medicine. So welcome, Dr. Fatinas, and thank you so much for joining us today.
Are you able to hear me now?
Yes.
Great, okay, thank you. Yes, thank you for the invitation. It's my pleasure to come talk to you all, and really, I'm going to spend the next few minutes highlighting both some of the state level work, but primarily with a focus on some of the activities and events happening in north central Washington. I'm not going to spend much time on prevention because Dr. Banta Green, who follows me, will be doing that. So I want to just start with pretty much not being able to advance my slides. There we go. This just shows a snapshot of overdose-related deaths in Washington State for 1999 through 2017. And the top blue line shows all opioid overdoses related deaths over that time period. And what you can see is that number has continued to increase, although a bit slowly. The number of prescription opioid deaths, which is the red line you can see, has trended down. Heroin-related overdose deaths have sort of stabilized, but what we're seeing now is an increase due to the synthetic opiate fentanyl. There is some good news in this, as you can see, in terms of prescription-related opioids. This shows a point that I want to make as it relates to, we have to think about more than just opioids. The red arrow points to the number of overdose-related deaths due to methamphetamine. Unfortunately, when people have experienced substance use disorders, often it's not just one substance that they are challenged in managing. So this shows both the increased potency of methamphetamines and their contribution to overdose-related mortality alongside those from opiates. And again, this is statewide information. I would be remiss if I didn't put my public health on for a moment. And again, we talk about opioids because they are the most near-term deadly to folks given the risk of overdose. But we also still have as many alcohol-related deaths as well as deaths due to suicide. And the deaths due to despair is a term that's been coined by a national agency that's sort of tracking this. And as you can see in Washington, when you add deaths related to alcohol, suicide, and drug overdose together, the trend is startling. So this is my plea to have us think about the whole person and all of the circumstances that person may be in. Opiates may be the most near-term and obvious, but really we have to think about all the behavioral health conditions that someone might be suffering from. This looks a little bit more specifically at North Central. This is a little bit of a dated map from 2016, but you can see in the North Central region that in terms of 2016, the overdose-related death rates were on the lower end compared to the state. And I will say that The number, looking more recently, the number of overdose-related deaths in Chelan has decreased, while the other 3 counties have seen an increase. And this is just another way to show it. These are all opioid-related deaths in the 4 counties of North Central. The silver line shows the trend in the state, and the blue line shows the trends in North Central. So overall, matching, the numbers are small, so you can't make too much of the difference, but certainly you are aligned with other overdose-related mortality in the state and trending downward, which is good. I show this slide because, again, overdose-related deaths are the most obvious thing that we're trying to prevent in the near term. But for every death, there are about double that of overdose-related hospitalizations. There are non-overdose-related treatment admissions as well as hospitalizations, and people who are misusing before they get to the point of developing a substance use disorder. So just like it's important to think of more than just opioids in terms of substances, it's important to think about the broad range of effects that opiates have beyond overdose-related mortality itself. And this shows a more specific look at North Central in terms of hospitalizations for overdose. And I just highlight Douglas County as having one of the higher rates in the state for overdose-related hospitalizations. But again, when you think about the mortality slide, a few slides earlier, did not show an increased mortality rate. So I don't know what to make of that, but might bear some focus on overdose prevention efforts in Douglas County if you're thinking from a accountable community of health perspective. Excuse me. I point this slide out. These numbers are small. There are disparities, and certainly with you having the Colville Nation, what we know is that overdose-related deaths are disproportionately high in Native American communities, almost fourfold that in Caucasian white communities. So tells us at the state level that we need to be particularly good partners with our tribal nations and really work together to help meet the needs of their communities in addressing the opiate crisis and attendant overdose-related deaths. I will say that nationally, this is no longer just opioid addiction is no longer primarily disease of white communities. African American, Latino communities, with the advent of synthetic opioids and fentanyl, are seeing an increase in overdose-related deaths as well, unfortunately. Washington has been working hard on this the last number of years. This shows the outline of the Washington State Opioid Plan, which we started to develop in 2015. Governor Inslee put out an executive order in 2016, which really brought attention to the plan and gave us directions for things to focus on. It's really grouped into 4 phases. The first is to prevent opioid misuse and abuse, and Dr. Banjo-Green is going to focus a bit on that piece. The second goal is to treat opiate use disorder, expand access to treatment. And when I go through the rest of the slides, when I talk about treatment, we know that medication, particularly opiate agonist therapy, is the most effective treatment to reduce the risk of overdose death in people with opiate use disorder. So our attention has been focused on increasing access to medication and the number of people receiving it. The third goal is to reduce morbidity and mortality, primarily by distributing naloxone to reduce to respond to overdose-related events, and then we want to track and make sure that our efforts are working. This past year, we added 2 new subpopulations of focus. Those are people who are pregnant and parenting. We recognize there are gaps in identification and helping those parents bond with their infants in that newborn period, as well as people transferring from correctional facilities into the community because their risk of overdose is so high. Pardon me 1 second. Prevention areas in North Central, there are community prevention and wellness initiatives. In Grant County, there's the Quincy Coalition. Each site has a student assistant professional at the local school district who can provide prevention and intervention for students. There are community-based organization prevention grantees in Chelan Douglas, which is Together for Youth. There are 2-page reports of opioid prescriptions in the local area that the school districts receive. There are 5 in North Central. Starts with 1 is a media campaign launched by the Healthcare Authority, started last year and it's expanding this year, to talk about Opiates. What are they? How do we protect our children from them? How do we think wisely about when we need them and how to dispose of them? As well, prescriberless sports and parent-child assistant case management program in Chelan, which helps women and their babies work on parenting skills, provide support in case management and early childhood. Prescribing interventions, there are many. The providers in the audience, if there are any, will know about the 1427 prescribing rules. Those were mandated by the legislature to give us, millions of physicians, nurse practitioners, osteopaths, clear guidance on how we need to think about prescribing opioids, improving access to the prescription monitoring program. The providers are getting feedback reports. A number of prescribing guidelines have been administered, particularly by the agency medical directors group for the dental program and perioperative surgery events, and a number of educational conferences have been held. Most recently, the dental prescribing guideline was reviewed in 2 conferences on either side of the state to help, I'm sorry, I have the flu, dental providers better prescribe. This shows a little bit closer picture of the trend in prescribing over the state. The top blue line on the left panel shows the number of patients prescribed a chronic opioid or any opioid per 1,000. And what you can see is that number has trended down quite a bit from 2012 in the first quarter of last year. If you look below, the orange line shows people with chronic opioid use, and that means greater than 60 days in a 3-month period. Below that is the number of people on a concurrent opioid and sedative, a benzodiazepine, or another sedating medication. And the bottom line shows the number of people on chronic high-dose opioids. And what you can see is those are trending down. On the right, just a different look at the number of people, and overall trends are decreasing, which is good. This shows North Central, and really the point here is that all of the counties in North Central are following those statewide prescribing trends in decreasing the number of high-dose opiates, which is greater than 90 morphine equivalents, as well as decreasing the combination of opiates and sedatives together. And you can see the different counties. The numbers are small, so the variation, again, shouldn't be paid too much attention to. But the good news is people are being mindful of prescribing and being more thoughtful. At least that's what these trends suggest. The other piece which we have really focused on, we want to eliminate the extra amount of opioids in the community so people can't get into them. You know, people can't see what they feel like and misuse them. And so really limiting the number of acute days of opiate prescribing. And what this shows is that 84% of newly prescribed prescriptions as of the first quarter of 2018 were for 7 days or less. And that's fantastic. And so really we want to keep the number of short prescriptions high, the number of longer prescriptions lower. This is a busy slide. I'm not going to go through it, but it's to highlight the state has received 3 large groups of funds, 2 from the federal government, 1 through the state budget. There was $11 million each of 2 years provided in 2017 and 18 to really focus on expanding our capacity to treat people with opiate use disorder and to put into place prevention efforts. Most of the focus was to help provide support staff to practices in terms of nurses and care coordinators to really help providers who have a waiver to prescribe medication be able to manage and see more patients. The state put in its budget in 2018 $10 million to help expand what we're calling the hubs and spokes, which is the nurse and the care coordinators, to other parts of the state, focused on expanding the parent-child assistant program, increased the amount that providers who would use their waiver to be able to prescribe buprenorphine would receive, encouraging them to do so, and then helping to use that money to build up peer recovery supports to be able to train and help support them in working with folks struggling with opiate use disorder. And then we were also directed to do some of those things with the federal substance abuse block grants we receive every year. At the end of last year, the Support Act in Congress put out what was called state opiate response grants. Washington received $21 million each for 2 years, really, again, focusing on expanding our infrastructure, improving it so we can sort of take care of the whole person care of people with opiate use disorder. Prevention efforts you can see there, treatment efforts, really thinking about how we support those transitions in pregnant and parenting people and folks leaving jails and correctional facilities, and then really building up recovery supports. This shows that in Chelan and Douglas, there are 2 nurse care managers that were provided with that supplemental budget in 2018 from the state. Medication treatment, this is really to applaud the efforts of your community in managing people with opiate use disorder. This shows the number of people, This shows the number of people who have Medicaid with an opiate use disorder that are receiving medications, and that's about 35% in Douglas County, and statewide it's about 32%. Chelan, Grant, and Okanagan are not far behind. And even though not all the counties are at the state level, I would say this is good news. On average, it's estimated that only 10% of people with an opiate use disorder actually get into treatment. So your teams are doing well in identifying folks and helping get them into care and start on medication. This shows one of the things we know is that there are a lot of providers who took the training to be able to prescribe buprenorphine. But a lot of providers, at least those seeing Medicaid, are not using their waiver. I believe your Accountable Communities Health wins by far. You've got the vast majority of your providers who have a waiver, seeing Medicaid clients using them. That's stellar. So congratulations to whatever you've done to really encourage providers to step up and treat patients with opiate use disorder. That's really quite impressive, and a particular shout out to the nurse practitioners and physician's assistants who recently were able to get their waivers. And that just shows the statewide average. One of the things we know is it's not just enough to get people on medications, it's really important to support them maintaining them. The graph above shows how many people who were started on medication, and this is specifically buprenorphine, this doesn't show any of the methadone clinics. Of the people who were started on buprenorphine, how many people are still on it at 3 months? Recommendations are people should be on it at least 6 to 12 months to really have the best solid chance at long-term recovery. And statewide, about 72% of people started on medicine are on it at 3 months. Chelan, you've got 82% of folks still on it at 3 months. You can see in the other regions, not quite at the statewide average, but that gives you an area to say, gosh, how do you need to keep people on medication longer to help support their recovery? And below looks at those numbers for 180 days. And again, Chelan has some best practices. Clearly, they're well above the state average in keeping people on their medication treatment. And again, pardon me, the other counties may be able to get some pearls from them. So in summation, the rates of drug and overdose-related death rates in North Central are pretty much matching those of the state. There are some community resources that have been made available by the state to support both prevention and treatment. Your providers are doing an excellent job, reducing the number of opioids prescribed and helping identify and get folks on medication treatment. And really the next focus, I think, or one of them will be important, how to identify people and keep them maintained on their medication for the chronic condition of opiate use disorder so they can continue to move towards recovery and help improve their lives. Thank you very much. And now I'm going to introduce Dr. Caleb Banta-Green. Caleb, I asked him how he wanted to be introduced, and he did not really give me much. He asked that I say he's the principal research scientist at the Alcohol and Drug Abuse Institute of the University of Washington, and he has worked in this space for 20 years. Caleb is a fantastic partner in terms of someone to work with in this. He is passionate, he is smart, he's well respected, and we're really lucky to have him in his state. So with that, I will turn it over to Caleb.
Great, Dr. Patinos. So I'm going to focus on prevention-related efforts and mobilizing. Telling me I'm muted, but I don't believe it. Can you hear me okay? Can you hear me okay? I think I'm hearing a yes. I'll keep going. Somebody starts going like that, I'll know. Good morning. So I'm going to talk about mobilizing rural communities around opioid prevention, and I'm really excited to be joining you. I was last there 4 years ago in Central Washington University, helping sponsor an opioid summit. So I'm really happy to be back with you all and have a much larger group. This is a really important topic, and your efforts are going to be a major part of us getting success here. I'm going to focus on early primary prevention, and I want to share a broad range of prevention resources. So this is really introductory. I want to point you towards some resources that are available online and set really the framework and context for this work. Okay. So I'm going to give a couple of data highlights. Dr. Patinos did those. I'm going to give a couple that focus on prevention. I'm going to talk about the full range of prevention interventions so you can see sort of what the full toolkit looks like. And the idea is we have lots of tools you'll need to figure out what works for your community. I want to really focus, as I said, on primary prevention. What are the household conversations about medications like for any kind? Really this idea that health beliefs inform medication usage beliefs, inform drug use beliefs. And then specifically around primary prevention, around pain and opioids, and then really want to focus on pointing you to a whole range of really great information and resources. So we really have the tools out there, and it's really you assembling and finding out what's the best fit for your community. So I just want to, for background, just mention, the CDC has been looking a lot at what are the trends in different communities, and really has a really nice research piece about a year and a half ago. Looking at the trends, and their highlights were that drug use and subsequent overdoses are continuing to be a critical issue both in metropolitan and non-metropolitan areas. The good news is we actually are starting to see declines in illicit use by youth and lower prevalence of use disorders in rural areas. So we're already starting to bend the curve to some degree in terms of this next young group of people coming into opioid use disorder. But there are increasing rates of drug overdose in rural areas. So those are actually in many places surpassing what we're seeing in urban areas. So my punchline here is, while it's really important to remain vigilant and expand these prevention efforts, we need to, in order to improve public health in the short and long term, we have to integrate this work within the treatment and recovery support and mortality prevention efforts. Just to highlight this again, this is an understatement of what's going on. This is looking at opioids sold in Washington State just from 2005 to 2015. And what you see here is a massive increase. And in fact, it started a decade earlier than this. Where in 2011, at our peak, we had 111 million daily doses of opioids sold in Washington State. So just a staggering amount of opioids. And kind of the fundamental issue that's going on here is that we have us as humans have a natural predisposition towards opioids, but historically, most of us weren't exposed to them. And now many of us are. In fact, the majority of us are, which is a major reason for this massive change we've seen in the last 20 years. In 2006, we added a question to the Washington State Healthy Youth Survey, basically have you used prescription opiates such as Vicodin and Percocet to get high in the last month. So that wording is really important. We want to focus on past month. We really want to focus on this intent to get high. That's really what we're concerned about. And in a very heartening thing, I think a very positive intended consequence of the reining in of opioid prescribing and the beginning of these conversations, we went from 10% of high school sophomores reporting use in the past month to get high to 4% in 2016. 2018 data are not out yet. But I think it's really important that we see we are going in the right direction. It's still too high. But part of the challenge we're facing 13 years later is we had 3 kids in every classroom who'd used prescription opiates to get high. And if one of them moved on to opioid use disorder, that proportion ends up across the state being truly staggering. And that's what we're grappling with. And this age, the sophomore age, is very important, and I highlight it for a reason. There's several nice research studies that show the peak age when people are most likely to first misuse the pharmaceutical opioid is 14 to 15 years of age. So what's important to understand is that is a really vulnerable time. We certainly need to be vigilant during that period of time. But you don't suddenly establish your health beliefs and medication beliefs and drug beliefs at age 14 or 15. That's been happening for 10 years. So we're going to talk about how do you really work upstream of that. And this isn't really important, I think. Even at 10th grade, the strong association with heroin use. And what we basically saw is that if you had not used prescription opiates to get high in the last month, 2 or 3% of folks had used heroin. But if you had used prescription opiates to get high in the last month, a quarter had used heroin. So a really, really strong association. And we've done a lot of other research that shows that is, of course, a causal relationship, that exposure to pharmaceutical opioids in the context of using to get high. So that set and setting is really important to focus on. In the context of using to get high or seek escape or seek release or relief from trauma really is very, very priming for future misuse and addiction. This is a bit complicated, so let me walk through this. This is Washington State. This is just publicly funded treatment data, so this is a gross underestimate of the actual numbers that we're talking about. But we're looking at people who had never been in drug treatment before, and the first time they came into treatment, their primary drug was heroin. That alone is unusual. You would think the first time a person comes into treatment, it's more likely to be for alcohol or marijuana. They're so much more prevalent. But this is just looking among people coming in for heroin the first time. This is unduplicated data, so these are unique people. And what we saw back in 2002 is we had about 700 people came into treatment for the first time for heroin, and it was kind of evenly split between people 45 and older, 30 to 45, and 18 and 29 years old, and we basically saw no adolescents. And within a relatively short period of time, we saw a massive increase to 2,300 folks, and now the majority are ages 18 and 29. We went from minority being young adults to a majority being young adults. And as Dr. Patinos was talking about, opioid use disorder is a chronic, lifelong health condition. And so if we want to keep our communities and keep people alive and keep them healthy and keep them functioning and keep them engaged, we have to figure out ways to engage people humanly in a non-stigmatizing way, as well as with effective medical treatments and appropriate counseling and social supports, so that these young adults can become old adults. We don't have a quick fix. We need to figure out rethinking our ways of considering this epidemic and engaging with people that is going to last at least a couple generations, so these young adults can become older adults. Don't worry, there's not a quiz. I'm not going to read all of this, but I want you to know this exists, and we'll certainly show the slide so you have this for reference. But I use this oftentimes to make sure that people know we know a lot of what to do, and also how this continuum intersects with other aspects. So we really, our goal, and I think we're really talking about today, is trying to prevent the inappropriate initiation of opioids. And if we don't, that can escalate into opioid use disorder or chronic pain. And both of those overlap occasionally, actually fairly oftentimes, and they can be dealt with similarly in some situations. And then there also is this dynamic that we got to keep people alive. And that's about both improving functioning, reducing morbidity and mortality. And that's around both overdose and infectious diseases. And of course, we are obviously trying to prevent death. And now I'm going to just go into a little bit more around the prevention aspects here. And as you're thinking about what you all want to do, thinking about the populations, are we targeting or reaching out to the general public? Are we talking about prescribers? Are we talking about patients? Are we talking about youth? And as you'll hear me say probably several times, there's a lot on the supply reduction side that's really important, but the demand reduction side is really important as well. Particularly on the prescribing side, if you continue to have patients demanding pain medications, and that's going to continue to put pressure on providers and systems to actually deliver them to those folks. So we want to try to tamp that down on both sides, both the supply and demand. We can't expect just one thing to drive the entire system. So on the supply reduction side, the things we think about are obviously law enforcement efforts to make sure illicit opioids, whether they're pharmaceuticals or things like illicit fentanyl or heroin, are not available to folks. Prescribing practices are obviously a critical piece, not what we're really talking about today. Pain management practices are very important. Lock boxes, when you do have meds, securing those, we'll talk about that, are important. Medication disposal is an incredibly important way to just really low-hanging fruit that can really suppress a lot of what we're seeing. And then prescription monitoring to ensure that we really are prescribing opiates when it's appropriate, know that they're getting prescribed, that providers can coordinate that care and so on is really an essential piece here. And then I think what we're really focusing on today is what we call demand reduction. And really, I think that is a lot about education and beliefs around health beliefs, medication beliefs, and ultimately how we deal with pain and stress. And then the care settings we think about are places like medical care, healthcare systems, pharmacy settings, schools, homes, and more generally in a community. So thinking really upstream around the messaging, really want to start at a really early age. I like to say when a kid can get through, I should have brought this out earlier, when a kid can get through the medication safety cap, what's the next device and what's the next message? And that's pretty early, right? I don't know about your kids, but I think that was around age 4 or 5 for my kids. So really being ready for those conversations and having a plan. I think important pieces of that message are that parents are in charge of medicines, whether it's ibuprofen or Vicodin. The medications can be dangerous if they're not prescribed to you, use more than prescribed, or you use with alcohol or other medicine. It's just essential that people understand this thing. And it is important to understand that medications can help with a medical problem, but in rare situations, except for things like diabetes or cancer and so on, often medications are not just fixing a problem. They don't fix it all by themselves. There are other things we have to do. And it is true, obviously, with diabetes, depression, and hypertension, a whole range of issues. There are many different things we have to do. Medications may or may not be part of the equation, but only in rare instances are they the sole fix. And it's important to understand that being healthy requires exercise and eating well and social connections. It doesn't, unfortunately, I wish it worked, but diet chocolate cake does not actually make you healthy. So what I want to focus on and kind of deconstruct here a little bit is an educational flyer that's available online. Here's the webpage, and we'll send the slides around. And this is, I think, really important. This was put up by the Washington Health Alliance and a BREE collaborative. This is really looking at opioid pain medications and what you need to know. And this is so important. And I'll say this really generally, and I think my most basic message is that we all experience emotional and physical pain. That is a normal part of life. What we need to figure out and communicate is why and whether we medicate that pain, whether it is with alcohol, prescription medications, or illicit drugs. Why do we do that? And as adults, what are we advertising and modeling all the time that is reinforcing messages that we may not actually want to be sending? So I'm going to just walk through this really slowly and just chat about it a bit. I think it's really important. And here's this idea, right? So if you've had an injury, surgery, or major dental work, you're likely to have pain. It is a normal part of life and healing. You need to talk with your healthcare provider, not just your doctor, about how you can get the most effective pain relief with the least risk. And also to understand that there rarely are you going to get pain relief that makes all pain go away. That's really important to have reasonable pain expectations. Important thing to convey is that non-opioid pain treatments have fewer risks. Again, for pain that's likely to be gone in a week or two, whether it's a sprained ankle or a minor surgery, it's always best to start with non-opioid pain treatments. Opioids may help control pain at first. They usually are not necessary. And in fact, there's a lot of research showing really quite convincingly that medications such as ibuprofen and acetaminophen are as good, if not better, than opioids for most of these types of conditions, and really emphasizing that these opioids are really a medication of last resort. And so these over-the-counter pain relievers are very effective. Physical therapy is very effective. Exercise is very effective. And then also professional help coping with the emotional effects of pain. It is not at all uncommon. In fact, it is very common for people with long-term pain to develop both anxiety and depression, which is a really vicious cycle. And so with that, we need to not just be trying to treat that underlying pain and think that's going to address everything. We need to think about the symptoms of anxiety and depression and how to directly address those as well. Opioids are strong prescription medications. They can be the right choice for treating severe pain, such as cancer right after surgery. But these medications are very, very powerful and can be deadly. I think that's probably moderately clear to people at this point that they can be deadly. But I think, being a parent of adolescents, people still think that they are immune. And I think this is what we're going to say in a moment here, really understanding that these things aren't distinct from heroin except in name. So even if you take these medications as directed, all opioids have serious side effects, such as addiction and overdose. And the point here is, I want to be really clear, is that not everybody who takes opioids for long-term becomes addicted. In fact, most don't. They become physically dependent, as Dr. Fatino's talked about, but they don't move on to addiction. So we want to be careful to be having accurate messages for folks. So the idea with opioids is everybody on this call right now takes opioids every day for a month. We're all going to become physically tolerant. And we need to understand that physical tolerance is a normal biological reaction. Some people move on to opioid addiction for various reasons, either genetic predisposition or a history of trauma or a history of other substance use disorder. And then to the point that Dr. Patinos made earlier, you can actually be on medications that are long-acting state opioids and be out of the chaos and disorder of addiction, but still physically dependent. So within that context, it's kind of important to understand around taking opioid pain medications. The higher the dose, the more dangerous the opioids are. You can become addicted after a relatively short time. We should say that relatively short time is really weeks and months that you actually become addicted. But I think what can happen in the short term, and it really is not what you want. The paradoxical reaction to opioids is the person who says, I felt good or energized or normal. Those are all giant red flags when it comes to opioids. That's very, very concerning when a person has that reaction to opioids. And that is, again, a combination of both genetic predisposition and also social and psychological circumstances. But it's not volitional. It's not a choice that people have. They just often can respond that way. So what? If you are prescribed opioids for short-term pain, and this is really targeted to adults. I'm going to talk about adolescents in a moment. Really, the prescription should be short. 3 to 7 days is fine. And the reason for that is that the typical pattern that we find of people actually using opioids is they either use none, 2 to 4, and in a minority of cases, all of them. And I think where we've gotten into all of this is prescribers worried about getting called over the weekend. And so, an adequate supply perhaps to get through a weekend, but not a supply that's going to last multiple weeks. It's also important to understand that you want to take the lowest dose possible for the shortest period of time. And that's true of most medications. Obviously, it depends on your medical condition, but certainly for opioids. And then you always want to talk to the prescriber about managing pain better without taking prescription opioids. So a couple more of these facts and figures. I'm really just going over this because it's on the back of the flyer. I want you to know what's on that flyer. So as was already mentioned by Senator Parlett earlier, drug overdose is the leading cause of accidental death in the United States and in Washington State. And opioid addiction is driving the epidemic. Over 2/3 of drug overdose deaths involve opioids. Most of those deaths involve multiple substances, which is important to understand. Things like anti-anxiety medications, alcohol, methamphetamine, a range of other substances. But the opioid is really one of the main drivers of what we're seeing around opioid overdose. Huge numbers, as we're already pointed to in Washington State, absolute numbers. I said that the majority of overdoses involve an opioid. This number is a little bit tricky. It says 4 in 5 new heroin users started out misusing prescription painkillers. I personally think that's a bit of a misleading statement. The vast majority of people are prescribed an opioid, and misuse can mean a bunch of different things. What we really try to focus on in research that I've done here in Washington State is we ask people at syringe exchanges, so these are opioid injectors, were you hooked on prescription opiates before you began using heroin? And in that case, it's now the majority of folks saying that, over half of people are saying that they were hooked on them first. And the reason, just to state once again, and I think it's important to recall, is that heroin used to be an over-the-counter and then a prescription drug in the United States, and only now is it illegal. It was made in a laboratory. So the only difference between OxyContin and heroin is some minor molecular changes, or minor molecular differences, and the fact that one of them is currently legal and one is currently illegal. But to the brain, they are seen as the exact same thing. The issue is that to the wallet, they may not be. That is, the illicit drugs are far cheaper and easier to get a hold of. So specifically regarding teens, as we talked about, nearly half of young people who inject heroin started off abusing prescription drugs. Among young folks, more than 4 in 10 who misused these drugs took them out of their parents' medicine cabinet. I will say there's been some really nice research. It's really a mix of whether people end up misusing their own medications, taking them out of the medicine cabinet at home, or getting them from a friend. It's a roughly even mix of all of those things. And we really want to think about how do we impact and suppress all of that, so we're preventing that inappropriate initiation. And parents, 95% believe that their kid has never taken a prescription drug for a reason other than its intended use. So clearly there's a lack of knowledge on the part of parents. So then, in thinking about what to do, particularly in the context of adolescents, really think about a really short day supply here. Really talking about a 3-day supply, maximum 10 pills. And it's important also for prescribers to not get too stuck just on the day supply of pills, because some of those pills are really potent. It's also really trying to think about a modest dose as well. Securely storing those meds is really important. And the reason for this has to do with addiction priming. If my kid has a Vicodin prescription, it is very, very different in terms of his opportunity and his chances of becoming addicted, whether he gets that Vicodin from me in the kitchen 3 times a day being supervised, or whether he takes that to a kegger and starts sharing it with his friends. The chances of addiction are different in those different settings, and that's important to understand. So that storage is really important. And the biggest piece really is around disposing of those medications as soon as you are done with them. Not when you remember, not a year later, not spring cleaning, as soon as you are done with them. Just don't keep them around. Given our healthcare system, if you're going to need more eventually in the future, you can get them. Just get rid of them. I think we think of them as sort of a valuable commodity that we want to keep around just in case. So I want to move in here just to give you a very high level overview of some resources, and then we'll wrap up. I want to mention the CDC has some really nice materials about preventing opioid overdoses in rural America. And these web pages are here. And among those things are increasing adherence to evidence-based prescribing practices. The CDC has put out some very nice guidelines for opioid prescribing, and those can go a long way to continue that bending of the curve around opioid prescribing. And then, the most potent thing we can do for those who have opioid use disorder, we know, is the use of medications such as buprenorphine and methadone have fantastic mortality prevention effects, 40 to 80% mortality reduction, and really strongly support recovery. We do a lot of work around overdose prevention as well. I know you're going to talk about Narcan, and Narcan is a really valuable intervention. It has a significant impact on those folks whose lives it saves. It has a statistically significant impact. But it's important to understand that on an order of magnitude, if this is the impact that opiate use disorder treatment medications have, Narcan, while essential, has a much smaller impact. It is not a solution by itself. Nobody should be satisfied that they've done everything they can by just implementing Narcan distribution. An essential component, but not sufficient. SAMHSA is really our main Substance Abuse and Mental Health Services Administration, puts out a whole range of whole prevention toolkits, both primary prevention as well as overdose prevention. I won't go into great detail, just go to the samhsa.gov webpage, and you'll see there's a strategic prevention framework you should be aware of. And I think these stories are really important to see. Hey, this is how this worked in this community. It can be really overwhelming when you see this giant toolkit to know, I don't know where to start. But if you can get a story like, oh, this community sounds like my community. We're really dealing with teenagers partying, and that's this main thing we're dealing with. Or we're really dealing with, chronic pain patients whose meds are getting stolen. Whatever it is, really trying to figure out what the story and stories are in your community and what interventions are going to fit best. For Washington State, we have the athenaforum.org. You can see here, and this is really taking a lot of the SAMHSA materials and really trying to scale them and develop them and adapt them for our local communities. So this is a really wonderful resource for you. You can see down here the Washington Prevention Services map and a whole range of resources that I really encourage you to take a look at. Another institute which I get research funding from is the National Institute on Drug Abuse, and this is some of their resources, particularly focused on adolescent health. And I think they've got great materials both for teens themselves, and I think it's important. The scared straight thing never worked, and what teenagers really need is they need facts. They know when they're getting spin, they want facts, and they've got really nice fact-based information on NIDA's webpage, and I really encourage you to take a look at that for people to understand what are opioids, what is opioid use disorder, what can I do about it, is really an essential component here. We've got nice materials for education professionals, healthcare professionals, and then also out in the community as well. And then almost last but not least at all is the Washington State Recovery Helpline. They're a fantastic resource, and we've been working with them for several years. And I want to share with you sort of two things that have really motivated our work with the Washington State Recovery Helpline. There's two situations, and I've listened in on many calls there. So one situation is a parent calls and said, my teen is on heroin, I got to get him in detox today. And historically, we'd say, okay, who's your insurer? Here's your closest detox provider. What we're now saying is we can give you that information, but you also need to understand that detox is not a treatment for opiate use disorder, and in fact can be counterproductive because it interrupts tolerance and actually increases the risk of relapse and fatal overdose. And similarly with inpatient, Without the use of medications for adolescents, you're really exposing that young person to extreme risk for relapse and overdose. The Washington State Recovery Helpline has now developed this medication-assisted treatment locator. You can put in your information as well as some issues around, is the person using multiple substances? Are they homeless? And so on. And really trying to make that first connection with a treatment provider the right one. Too oftentimes, we call a treatment provider and they'll say, yeah, we don't take your insurance or we don't have space. We want to do away with that because that wall, when a person's finally ready to reach out, is really dangerous. We want a person to have that door open, not just face a closed door or a wall they can't even figure out how to penetrate. So I really encourage people to know about the Washington Recovery Helpline. They have great staff and volunteers who can talk through what are treatment options, where can you get good counseling supports, what are recovery supports in your community, as well as how medications might fit into the treatment continuum. And then just want to wrap up here with our web pages, the Alcohol and Drug Abuse Institute webpage. We have a whole range of information with a lot of information, people, a lot of questions about marijuana, how marijuana relates to pain, how it relates to opioids. We have a lot of good resources on that. Links to a whole bunch of research and such. And then the other thing hopefully you know about is our webpage, stopoverdose.org, which is information on sort of what is an overdose, what is naloxone, how do you get it, how do you get help, including treatment resources, great information for professionals, whether they're teachers, nurses, medical providers, law enforcement, great information for law enforcement providers, as well as other resources. So I think that's it. I'm going to wrap up there. I'm a couple minutes early, which is a rare feat on my part, but I'm happy to join you all and hope some of this information helps inform your conversation today and provide some useful context. Thank you very much.
All right. Thank you, Dr. Fatinas. Is there still an echo? Hello? Let's see if I can do this. Thank you, Dr. Fatinas and Dr. Bantagreen, for those wonderful presentations. I think they gave us a lot of food for thought for our conversations that are going to happen today at each of the sites. I do want to mention that the North Central Accountable Community of Health currently has an application open for up to $10,000 for agencies to apply for opioid prevention treatment, overdose prevention or recovery, and group facilitators at each of the sites has that information. So ask your group facilitator if you want to know more about that. And so now we'll turn it over to the group facilitators for a group discussion and local action planning activities. And I hope you guys at all the sites have wonderful, energizing, and meaningful conversations today. Thank you for joining us.
All of you before we go to break. Incredible presentations. Both of the presenters there have done huge amounts in this